I get that annoying feeling like food is just sort of hanging out in your throat, not going down properly.
Mm.
Or maybe a cough that just keeps nagging you.
Yeah.
Okay, let's unpack something pretty fascinating today.
Yeah.
We're taking a deep dive into pharyngeal pouch. You might also know it as Zenker's diverticulum.
That's right, Zenkers.
Think of this as your, express lane to understanding what it is, why it happens, and what can actually be done about it.
Yep, covering the essentials.
We've got our notes ready, and we're going to distill the key stuff. So this condition affects the pharyngeal wall, specifically the hypopharynx, that's the lower part of your throat.
The very bottom section.
And it develops in this weak spot called Killian's dehiscence. Imagine like a brick wall, and one small section has missing mortar.
Good analogy.
That's essentially Killian's dehiscence, a weak point where this pouch can bulge out.
Exactly.
Now, this little issue tends to show up more in older individuals, and here's a striking point. It's about 5 times more common in men.
5 times, yeah. That's quite significant.
Ever wonder why some people might experience food coming back up like long after eating? That could very well be what we're talking about today.
Exactly. So to really nail down what we're discussing, a pharyngeal pouch, or Zenker's diverticulum, is, it's a pouch that forms in that lower part of the throat, the hypopharynx.
Yeah.
And the crucial thing to remember is its origin. It develops because of that weakness at Killian's dehiscence.
Right, that spot you mentioned.
Right between 2 specific muscles, the thyropharyngeus and the cricopharyngeus.
Okay, so the location is key.
The location is absolutely key. And you're spot on about who it tends to affect: older folks. And that significant male predominance, the 5-to-1 ratio, is a really important demographic to keep in mind.
Okay, so we've got the what and the where. Now, what's the why? What actually kicks off this pouch formation in the first place? What's the underlying story?
That's a really insightful question, and the honest answer is that the precise cause isn't fully understood.
Ah, okay. Not totally clear then.
Not completely. However, the leading thought, the main theory, is that it's connected to some sort of hiccup or discoordination in how the pharyngeal muscles work during swallowing.
Like they're not working together smoothly.
Exactly. This uncoordinated action is believed to put extra pressure on that weak spot, Killian's dehiscence, and eventually leads to the pouch forming over time.
So while we don't have one single culprit, it sounds like it's more about a problem with the kind of mechanics of swallowing. Yeah. And how those throat muscles are interacting.
That's the current thinking, yes. It's about the mechanics and the pressure.
That makes sense. Now, are there specific things that might make someone more susceptible to developing this kind of pouch? What are the factors that increase the risk?
Absolutely. The most firmly established risk factors, as we've already mentioned, are older age and being male.
Right, the age and the 5.1 ratio.
Exactly. That 5.1 ratio is quite significant. Beyond those, individuals with conditions that can weaken the muscles in their throat might also be at higher risk.
Like what sort of conditions?
Well, this could include certain neurological disorders or maybe conditions that cause chronic inflammation in that area.
Okay.
Think of it this way. If the wall is already sort of compromised structurally, it might be more likely for this kind of pouch to develop under pressure.
Right, so age and gender are the big ones, and anything that weakens those throat muscles could potentially kind of pave the way.
Precisely.
Now let's get into the nitty-gritty of how this actually happens.
Yeah.
What's the step-by-step process of this pouch forming? What's the pathophysiology behind it?
What's fascinating here is the actual mechanics. It involves a herniation, essentially a bulging out of the mucosa, which is the inner lining of the throat, through that weak point in the pharyngeal wall, Killian's dehiscence.
So the lining pushes through the weak spot.
Exactly. This protrusion is what creates the pouch. And the consequence of having this pouch is that food can then get trapped inside it.
Ah, right.
Which, as you can imagine, can lead to difficulties with swallowing and those other symptoms we'll discuss.
Okay, so food gets stuck in this little bulge. Not a pleasant picture. Now, if someone is having trouble swallowing, dysphagia, there could be a number of reasons.
Oh, absolutely.
What other conditions might doctors consider before diagnosing a pharyngeal pouch? What's the differential diagnosis?
That's a really critical point. It's vital to consider other conditions that can have similar symptoms. These include things like esophageal strictures.
Strictures, like narrowings.
Exactly. Narrowings in the esophagus, think of it as like a narrowing pipe, making it hard for food to pass. Examples include esophageal webs and rings.
Okay.
We also need to consider esophageal tumors, specifically esophageal carcinoma.
Right. Cancer is always a consideration.
Unfortunately, yes. And as we touched on earlier, Neurological disorders that affect the throat muscles can also cause swallowing problems.
Hmm.
So ruling out these other possibilities is absolutely essential for getting the right diagnosis and consequently the right treatment plan in place.
Absolutely. You wouldn't want to overlook something else that might be going on. So this condition seems fairly specific. Do we have a sense of how common it is? What
Yeah.
does the epidemiology look like, say, here in the UK?
Yeah, when we look specifically at the UK, the precise prevalence is a bit uncertain. There aren't exact numbers widely agreed upon.
Okay, so a bit fuzzy on the numbers.
A bit fuzzy on the exact prevalence, yes. However, the patterns in who gets it are clearer. We know it's more common in older individuals.
Right.
And that higher incidence in males, that 5-to-1 ratio we keep mentioning, definitely holds true here.
Okay.
It's predominantly seen in people over the age of 70.
Over 70. Interesting.
So while we might not have exact population numbers, we have a good understanding of the demographic most likely to be affected.
Okay, so generally older men, typically over 70. Now let's talk about what someone experiencing this might actually notice. What are the telltale signs and symptoms? What's the clinical presentation like?
The symptoms can actually be quite varied, The common ones include dysphagia, which, as we know, is difficulty swallowing. That's often the main complaint.
Right.
Patients might also experience regurgitation of undigested food.
That's the food coming back up.
Exactly. That food coming back up sometimes quite a while after eating, which can be quite surprising and unpleasant.
I bet.
Aspiration, where food or liquid goes down the wrong way into the airway, is another serious concern.
Yeah, that can lead to lung issues.
It certainly can. Halitosis, or bad breath, is also frequently reported.
Why bad breath?
Well, that's often because food can get trapped in the pouch and start to decay or ferment.
Ah, okay. Makes sense.
People might also experience coughing, especially after eating or drinking, and even recurrent chest infections as a result of that aspiration we mentioned.
Wow, that paints a pretty uncomfortable picture. Are there any physical signs that a doctor might look for during an examination? Anything they can see or feel?
Yes, there are a few things. Less commonly, a doctor might notice pigmented spots, like little dark spots on the lips, face, palms, or soles. That's quite rare, though.
Okay.
But a more noticeable and perhaps more classic physical finding is a swelling in the neck that actually gurgles when you press on it during palpation.
Really?
Yes, a gurgling sensation. That's a pretty distinctive sign that can really point towards a pharyngeal pouch.
Yeah.
Imagine pressing gently on a small water balloon filled with air and liquid, that kind of gurgling sensation.
Your gurgling neck swelling, that's definitely a key thing to listen and feel for. So if doctor suspects a pharyngeal pouch based on symptoms and maybe that gurgle, what kind of investigations would they typically order to confirm the diagnosis?
Well, the gold standard for diagnosis, the main test, is usually a barium swallow study.
Okay, the barium swallows, how does that work?
This involves the patient swallowing a liquid containing barium, which shows up really well on X-rays. It allows doctors to visualize the size and shape of the pouch and how it functions or doesn't function during swallowing. Often, this is combined with dynamic video fluoroscopy.
What's that?
It's like a moving X-ray so they can see the whole swallowing process in real time. It gives a really good picture of the mechanics.
Oh, okay. That sounds very useful.
It is. Interestingly, while you might think an endoscopy, putting a camera down the throat, would be the first step,
Yeah, it seems logical.
it's actually usually avoided initially. There's a small risk of accidentally perforating the pouch with the endoscope, especially if you don't know it's there or exactly where it is.
Oh, right. That could be dangerous.
Exactly. However, if a barium swallow has already been done and shown the pouch, an endoscopy might later show maybe a pool of the barium contrast sitting in the pouch, or just help visualize the area.
Okay. Any other tests?
Lastly, an indirect laryngoscopy, where a mirror or a small scope is used to look at the larynx and surrounding areas, might reveal saliva pooling in an area called the piriform fossa, which can also be a clue.
Right, so barium swallow is the go-to. And caution with that initial endoscopy. Okay, so we've diagnosed a pharyngeal pouch. What are the options for dealing with it? What's the management strategy?
Management really depends on how big the pouch is and how bad the symptoms are for the patient.
Makes sense.
For very small pouches that aren't causing any problems, sometimes just watchful waiting or dietary modifications might be enough.
Like what kind of modification?
Things like eating softer foods, chewing very thoroughly, maybe taking smaller bites, drinking liquids with meals. Swallowing therapy with a speech therapist can also sometimes play a role to improve coordination.
Okay. But what if symptoms are bad?
Right. For most pouches that are causing noticeable symptoms, surgical intervention is usually the way to go.
Surgery, yeah.
The choice of surgery depends on the size of the pouch and the patient's overall health, how fit they are for an operation.
What are the main surgical options?
Options include a diverticulectomy, which is the surgical removal of the pouch itself.
Okay, just cutting it out.
Essentially, yes, and often combined with a cricopharyngeal myotomy. That's where the cricopharyngeus muscle, the one at the entrance to the esophagus, is cut to reduce pressure in that area and prevent recurrence.
Addressing the underlying pressure issue, too.
Exactly. Then there are minimally invasive techniques using endoscopic stapling devices, which are becoming increasingly common.
Endoscopic, so through the mouth.
Yes, working through the mouth with scopes and staplers. And for smaller pouches, specifically, a procedure called Dolman's procedure might be considered.
Okay, so a range of surgical options depending on the specifics. Can we dive a little deeper into a couple of these, like the traditional diverticulectomy and maybe that Dolman's procedure? What exactly do they involve?
Certainly. For a diverticulectomy, which is typically used for larger pouches, it's often done through an open incision in the neck.
An external cut, okay.
Yes. A rigid endoscope might be used internally to help visualize and manipulate the pouch. The surgeon carefully dissects the pouch out and removes it, and then the tissues are closed up.
And the myotomy.
Yes, a really key step during this procedure is usually performing that cricopharyngeal myotomy. At the same time, remember, that's cutting that tight muscle to help prevent the pouch from coming back.
Right, prevent recurrence.
Absolutely. After this open surgery, patients usually need to be fed through a nasogastric tube, a tube through the nose into the stomach, for about a week to allow everything to heal properly without food passing over the site.
A week of tube feeding, okay.
And potential complications, as with any surgery, can include things like nerve damage, particularly to the nerve supplying the voice box, which could affect the voice.
Hoarseness.
Potentially, yes. Also, air leaking into the tissues, a condition called cervical emphysema, infections spreading down into the chest cavity, mediastinitis, and the formation of an abnormal connection between the throat and the skin called a fistula.
Okay, several potential risks there.
Yes, important to be aware of. Now, Dolman's procedure is different. It's a less invasive endoscopic approach that's typically used for smaller pouches.
Through the mouth again.
Yes. A special double-lipped esophagoscope is inserted. This instrument helps expose the bar of tissue that separates the pouch from the esophagus.
Okay.
And the surgeon then divides this hypopharyngeal bar, essentially opening the pouch into the esophagus, using heat either from diathermy or a laser.
So you're not removing the pouch, just opening it up.
Exactly. You're dividing the wall between the pouch and the esophagus, allowing food to drain out easily. The big advantages here are that it's minimally invasive, usually involves a shorter time under anesthesia, and allows for a quicker recovery, often eating much sooner.
That sounds appealing. Is one better than the other?
Interestingly, there's no strong evidence, no large trials, that clearly say one of these procedures is definitively better than the other overall.
So it depends.
It really depends. The best choice depends on the individual patient, their age, their health, and the characteristics of their pouch, like its size and position. Endoscopic surgery, like Dolman's or stapling, might be safer for more frail patients.
Less invasive.
Right. But it could potentially have a slightly higher chance of the pouch recurring down the line, or might sometimes require switching to an open procedure during the operation if things get complicated technically.
That makes sense. It's all about weighing the risks and benefits, the pros and cons for each individual.
Absolutely. Tailoring the approach is key.
And we mentioned post-operative care briefly. What does recovery generally look like after these surgeries, besides the potential tube feeding?
Well, as we said, after an open diverticulectomy, patients will likely need that nasogastric tube for feeding for about a week. Recovery from endoscopic procedures is usually faster, with patients often starting liquids or soft foods much sooner.
Okay.
Regardless of which surgical procedure is performed, doctors will be carefully monitoring for those potential complications we discussed: nerve damage, air in the neck, signs of infection like fever or chest pain suggesting mediastinitis, and any leakage suggesting a fistula. Pain management is also an important part of the recovery process.
Okay, so surgery can be very helpful, but there are definitely potential risks that need to be considered and managed. What about the overall outlook for someone with a pharyngeal pouch? What's the prognosis? And are there any long-term complications we should be aware of?
Generally speaking, the prognosis for pharyngeal pouch is quite good with appropriate management. Most people experience significant relief from their symptoms after successful treatment, whether surgical or sometimes even with conservative measures if symptoms are mild.
That's good news.
It is. However, if the condition is left untreated or if complications do arise, the main concerns are, as we mentioned, aspiration.
Right, food going into the lungs.
Exactly, which can lead to serious pneumonia, aspiration pneumonia. There's also a debated possibility of carcinoma or cancer developing within the lining of the pouch over time.
Cancer in the pouch itself.
Yes, squamous cell carcinoma. It's thought to be quite rare, maybe due to chronic irritation from trapped food, but the actual risk level is still debated in the literature. It's something doctors are mindful of, though. So while the long-term outlook is usually positive with proper care, those are the potential complications, mainly aspiration pneumonia and that small, debated cancer risk that doctors will monitor for.
So to quickly recap then, pharyngeal pouch, also called Zenker's diverticulum, is this pouch that forms in the lower part of the throat, the hypopharynx, due to a weakness at a spot called Killian's dehiscence, and it tends to affect older men more often, that 5.1 ratio.
That's the gist, yes.
Key symptoms include difficulty swallowing, dysphagia, and that regurgitation of undigested food, sometimes hours later. Maybe bad breath or a cough, too.
Correct, and sometimes that gurgling neck mass.
Right. Diagnosis usually involves a barium swallow study, being careful with initial endoscopy.
The barium swallow is key.
And treatment options range from dietary changes for mild cases to various surgical procedures like diverticulectomy or endoscopic techniques like Dolman's or stapling, depending on the specifics.
A tailored approach, absolutely.
The prognosis is generally good with proper management, but potential complications like aspiration pneumonia need to be kept in mind. And there's that small debated risk of cancer developing.
You've summarized it perfectly. And just to reiterate, that anatomical location, Killian's dehiscence, situated between the thyropharyngeus and cricopharyngeus muscles, is a really fundamental point to remember for understanding why it forms there.
Got it. The weak spot between those muscles.
Exactly. Also, while surgery is often very effective, the choice between the different surgical approaches really comes down to the individual patient, and the characteristics of their condition size matters. Health matters.
Excellent. Well, this has been a really clear and helpful deep dive into the pharyngeal pouch. Really clarified things.
Glad to help.
If you listening are looking to explore this topic further, or perhaps you want more resources related to the MSRA exams, be sure to check out passthemsra.com and freemsra.com.
Good resources there.
Thanks for joining us for this deep dive today, and we encourage you to keep learning and asking questions about your health.